Welcome to Parallax by Ankur Kalra, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur Kalra, MD, interventional cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur Kalra, MD.
Hello, everyone. I have the distinct honor and privilege of having with me on the show today Professor Seni. He requires no introduction. He's very well known in the field. He's the chief of cardiovascular medicine, the department at Pope Giovanni XXIII Hospital in Bergamo, Italy. Now, for the listeners, and I'm sure all of us know, Bergamo is where the epicenter of the outbreak was for COVID-19 in Italy. And, unfortunately, Professor Seni did contract the infection himself. And as we were just speaking on the phone just before beginning recording, he's going to take us through how that experience was. But I'll obviously have him talk more about it than myself. Professor Seni, welcome on the show, and thank you so much for your time. I'm glad you're doing well.
Thank you. Bye to everybody. Thank you so much. I'm very pleased to be here with you to tell the story and to probably give you some advice that can be useful for how to face this terrible disease, this terrible infection.
Yes, we've been all watching the footage that has been broadcast to the world from Bergamo, and it's been disturbing to say the least, but also just to think about, our colleagues, like yourself, who've been at the front line of managing patients. It's been gut-wrenching, and it's beyond fathomable to even, put it in words as to what you may have experienced as a healthcare worker, as a physician on the front line. So please talk to us about that a little bit.
Yeah, we started to have the first sign of infection in the middle of February, but we didn't recognize it clearly how much was important in terms of epidemiology at that time. And then in the last week of February, we had this tsunami. We can call it tsunami because it was terrible in terms of number of patients that started to be positive and started to come to emergency department. And we had this incredible wave that came. And although our hospital is quite new, it's just 7 years old, and we have 85, we are ready for 85 beds for intensive care, we couldn't face it immediately in a some way efficient manner. And therefore, we started with the idea to create 3 different cohorts, one with suspected COVID positive, and another one with positive, and the third one with more severe advanced interstitial pneumonia. But then after 2-3 days, we could figure out that this was not enough. So we admitted only patients with a severe interstitial pneumonia and with symptoms. And clearly at that time, we started to have beds dedicated to COVID. And we started with 15 beds of intensive care, and we increased the number over the time. And now today we have 85 beds of intubated patients with COVID. And at the same time during this story, I started to have fever, and therefore I stay at home after one day, and we thought that was just a classical influenza at the beginning because it was in the middle of February. But then they didn't get me. They didn't give me a test, a swab, because they thought that I didn't have any contact with a patient with COVID at the beginning. So I stayed home for 5 days, and then I restarted, and the fever disappeared. But then I started to work, but then the fever started again. This is a problem of COVID. To have this fever that at the beginning maybe the same symptomatology and the same natural history of influenza. The fever disappears, you feel better, but then some days later start again, and maybe it can worsen suddenly. So I worked for 5 days with mild fever without having any swab, and therefore I stopped at the end of the second week. At that time, I received the swab, the test, and it was positive. And it required a long time to completely recover. What does it mean? Sometimes this infection can be asymptomatic, other times is mildly symptomatic. But those like in my case, is mildly symptomatic. It requires time to completely recover, to have a negative swab. And so I think two messages should be, I think I like to give you. One is to make the swab for healthcare professionals when they start to have also mild symptoms. Fever for sure, but also some other mild symptoms like cough, like other symptoms that are typical of influenza. Because otherwise the risk of spreading the infection by the healthcare professionals is truly high. And the second one, that you have to therefore protect the healthcare professionals against this. Actually, in my division, we have 12 physician cardiologists that have positive swab. You can imagine how it's difficult to organize everything over the time. To organize, we double the colleagues that are on duty, because when you are called by emergency department, you cannot be alone to take care of patients. So you have to double the physician that are on call, because you are completely dressed with a so personal PPE, personal protection equipment, and therefore you cannot move around if they call you for something else. And this is something that you have to remind. And therefore, we move, coming back to the story of Bergamo, we still have this wave. So it's a long tsunami. It's just not a wave. Hopefully, this will be not the same in your hospital, but it's something that you have to predict in somehow, and to predict what is the worst scenario that you can have. Therefore, another aspect is the medicine that you can maybe face against this disaster. And you can think about selection of patients, which patient can receive the intubation. This is a dramatic choice that probably is not depending on mainly by cardiologists, but mainly by intensivists. But you have to think to prepare a triage for this, a triage in which they can be involved, the intensivists, the pneumologists, maybe also other professionals, in which you have to decide who is going to be intubated or not. And this must be, we use our score that probably we are going to validate that take into account different items, not only the age, but comorbidities, severity of ventilatory status, and just to think about which is the best patient for intubating, to be intubated in terms of life expectancy. And another thing that I would like to stress is how much is important the flexibility of your organization system, in which you have, of course, typical organization of hospital with different wards and division, but you have to think to move around, to create COVID wards in which most of the different specialties disappear and became a specific COVID division, in which they work all the physicians that are involved in medicine. It means also pathologists, also microbiologists, because with the problem of positive swabs, you can be alone after 1 month of the disease. And another aspect regarding the cardiovascular that we are facing in Lombardia region, my region that has 10 million people, they decide to centralize in different hubs. For instance, my hospital is a hub of 1.2 million people. And what is interesting that we saw a clear decrease in the number of STEMI and STEMI and acute heart failure. Why? We don't know. I think no one knows right now the current answer. Probably because the patient prefers stay at home with the pain instead of to come to the hospital. In particular, Bergamo has a problem that we have so many patients. We have something like now 100 patients admitted every day to emergency department for COVID, for respiratory failure. And therefore, there are other explanations that can be the differential diagnosis of symptoms of this disease with, for instance, acute heart failure, or since most of them have pain, like mild or moderate pain, chest pain, they can be confused. And the physician, although they perform an EKG in emergency department, maybe in the wards they cannot recognize. And we have some cases of this. And therefore, we have a clear reduction of the number. But this is true not only for Bergamo, but also for the other cities. And other explanation can be that at least in Bergamo, sometimes they have a problem to find the ambulance. Although we have a truly good network in the organization of emergency, you have a 911, we have a 118, but there are so many patients that are coming to emergency department due to the COVID that sometimes they have to wait for a long time on the phone calling this number, emergency number. So it's, in some sense, is an interesting question, it's interesting, let's say, we recognize this situation. Probably we are going to understand more in the next future. We are trying to figure out with other hospitals why we had this reduction. And other interesting aspects are related, I think, on troponin I. There are two different thinking regarding this. We are trying at the beginning to assess the troponin I high sensitivity troponin in all patients, but then we didn't have a clear increase with the typical wave of ischemia, and therefore now we are doing much less tests of troponin I. And what we can say so far, approximately 20 cases of STEMI, these patients have an incredible rate of death, due probably to the respiratory failure, but also due to probably this inflammation, general inflammation that they have. And we are trying to, at the same time, this time, to make some research, clinical research, but although it's tough because working on the patient 14 hours and trying to make a good research, honestly, it's not easy. We are trying because we do believe that this data can be truly valuable for everyone that is gonna facing this terrible infection.
Yes. No. Thank you for such a vivid description of what you've experienced. Just to summarize for the listeners, several take-home points from your discussion. One is obviously the issue of personal protective equipment for the healthcare worker, which I think is crucial. If you are not going to arm the soldier going into a war, you're not going to succeed in the mission. And then, the importance of being cognizant of, symptoms that you're developing as a healthcare worker, because you could be the vector that is then responsible for transmission to, not only your family members, but, your colleagues at work and the population at large, because that's how the virus is spreading. And then it just becomes a huge problem. Also you have to self-quarantine yourself. So you're sick yourself. You're also, like you said, I mean, you are increasing the burden on your physician colleagues to take care of patients. You are decreasing the healthcare workforce in a time where, healthcare workforce is needed at the front line because the sheer number of patients with this, lethal infection is just exponential. And is all happening at the same time, just like breaking the back of the healthcare system. So that's one message. I'm sure that's clear, has been clear with the experience in Bergamo, unfortunate experience in Bergamo. And then you really brought up a crucial point, which is each time there is a pandemic, we must not forget that other disease processes are not disappearing. They're still occurring. And, to experience a reduction in the incidence of acute myocardial infarction or heart failure is a little befuddling. But I think, like you said, it's just people are just heeding the advice of what is being told to them, just to stay at home and physical distancing. And or they're just scared of the infection. They are going to get themselves exposed when they visit hospitals with other illnesses. To not be exposed to the novel SARS coronavirus 2 infection. But important lessons again. I think the 20-odd patients that you did with STEMI and thanks for sharing that experience with us, because those patients, from what I've understood from the conversation, did not have a good outcome. I think it would be crucial to understand the mechanisms of adverse outcomes in these patients. Now, let me ask you this: Do you think, Professor Seni, the infection is leading to instability in stable disease, a stable coronary disease or plaque? Because that's been one of the theories of inflammation around acute coronary syndrome. And that's been one of the theories, even with influenza, like patients with concomitant influenza infection and acute coronary syndrome, I personally have looked at the data myself in one of the manuscripts, which is under review right now. But what do you think about this theory of infection, inflammation, and acute coronary syndrome?
Yeah, it's a good question. I do believe that these mechanism of inflammation play a major role in terms of stabilization of the plaque. And we were grow up with this concept regarding the fact that during influenza epidemic, you have an increased number of acute myocardial infarction, stemming or not stemming. But this is something that is amazing in terms of how is the result of this pandemic in terms of reduction of the number of patients with acute coronary syndrome. And as I say, there are different possible explanations. The scare of the patient to come to emergency department, the difficulty to find out the ambulance, the fact that the patient has changed a little bit the style of the life. They stay more at home. They are less stressful in some sense, although this disease make them more stressful for the fear of getting this disease. And but anyway, at the end, what we see that clearly there is a reduction of these patients. And what I forgot, but I think is really important, that what we are seeing now, that we have an incredible number of thromboembolic pulmonary embolism. And this is probably truly related to the inflammation, and therefore we are discussing which approach in terms of anticoagulation should be correct. And this is something that we are facing in these hours. And this could be in line with the fact that we should expect more infection, but I don't know what we are seeing. But this is not only in our center. This is true also in other centers all over Italy, not only in this epicentric place, but also in other that are in the north of Italy and also in the south of Italy. So we are collecting this data to see why we are facing this paradoxical epidemiology status that we don't know exactly why. But there are, as I say, different hypotheses, but it's really hard to understand clearly. Another aspect that I should, underline is the myocarditis. We have performed my center 20 autopsy and other center 21 in general, and we didn't have any patient that died in other department, so in other COVID division. They didn't find any sign of myocarditis at the histological assessment. And this is something that is also interesting, I think.
That's interesting. So, for myocarditis, was the suspicion based on echocardiography or rise in troponin with normal coronaries, or?
No, maybe I wasn't clear. I say that in 40 autopsies that were performed, in which the patient died without any suspicion of myocarditis, we didn't find at all. Today, unfortunately, one patient, a 33 years old, died female with a highly suspected myocarditis, because as all these clear symptoms, so this patient is going to be is going to have an autopsy, and so we will see. And this is clear, but we don't have so many.
I see. So just for the clarification of the audience, even though it has been reported out of the Chinese experience, in your experience, you did not see as much myocarditis with COVID-19 as reported in other series published.
Right.
Good to know. Thank you. Thank you for that clarification. What about acute onset of heart failure as a manifestation of the infection or cardiomyopathy? Because some of the critical care physicians and intensivists that I work with have voiced that concern. I mean, obviously the experience is so new to us in the US, and we're obviously learning about it as we take care of these patients. But just having the privilege of having you on the show, I just wanted to ask you this question of what you think about just acute onset heart failure from the infection itself.
This is an interesting question, because these patients can be misdiagnosed in terms of heart failure, because they can have increased natriuretic peptides, not so high, but they can be increased. The symptoms and signs sometimes are difficult to understand. For sure, the predominant symptoms and signs are due to respiratory failure. Although in some of these you can have a high output syndrome due to interpulmonary shunt, and this can be a cause of a high output syndrome congestion. And therefore, right now, I cannot answer clearly. For sure, a differential diagnosis can be difficult, because most of the time the patient is managed by other physicians, by other specialists, and not cardiologists. And therefore, when you look at the chest X-ray, it's difficult to say is just a pulmonary, interstitial pulmonary pneumonia, or there is also a pulmonary congestion. This is an intriguing question, that so far probably is difficult to answer, but it must be taught when you see the patient to try to make differential diagnosis. Using maybe the natriuretic peptide, higher level of natriuretic peptide should suggest you that this patient has both, and it can be.
Yes, so when you are experiencing a pandemic like COVID-19, obviously the top differential is going to be COVID-19 pneumonia, but like we discussed, other illnesses just don't disappear; they do happen. Was there an uptick in utilization of right heart catheterization to make a diagnosis of acute decompensated heart failure without COVID when you were experiencing this, or is this an irrelevant question because just the sheer number of patients were...
No. This is a important question, and we are doing this right heart catheterization. And there are different hemodynamic status in which you can have different hemodynamic parameter in terms of cardiac index that can be increased, can be the same. For sure, we don't have, apart the patient that have pulmonary embolism, we don't have any patient with increased pulmonary pressure. So this is an important message. That is make a little bit this disease different from ARDS. So there are some certainty, and we have performed quite a number of patients with the right heart catheterization so far. But we are analyzing this data right now.
Any closing remarks, Professor Seni? Thanks again for being on the show and your time. And, we obviously have learned a lot from your experience, and I'm sure we'll continue to learn a lot from your experience. And, I'm so glad, I'm sure everyone in the cardiovascular community is glad that, you're healthy and safe, and, you recovered, and you took the right steps, making sure the swab was negative before you resumed work. So we're very thankful and grateful that you're safe and healthy. Any closing remarks for your colleagues in the US who are now going to experience, unfortunately, what seems to be a tsunami of cases? I mean, it's already started happening in New York. I'm sure it's going to happen in other cities in the US. Any words of wisdom for us?
I would say that the most important message is to be very aggressive with the prevention of the infection in healthcare personnel. This is the most important message, because this is not a battle of one day, 1 month. It probably will be a long battle. So you must protect yourself, your colleagues, because otherwise, after 1 month, you will be alone to fight this battle. So this is something that you must require to your administration to have enough PPE for everybody, for all the professionals, for protecting yourself, for reducing the risk that you can lose colleagues during the time, and also because you can be the vector for infection for the patient and for the other one. Probably right now, this is the most important. The administration or the other people, they don't understand how much is important this. So another message regarding this aspect of prevention for the infection of the colleagues is also to require the swab just with mild fever and mild symptoms, because otherwise it's too late.
Yes, and just before I let you go, any prophylactic measures, any pharmacological prophylaxis that was administered to providers in Italy?
Unfortunately, no. I don't think, vitamin C can be, I don't know, probably 1 gram of vitamin C. But another point, more than therapy, we should use to take rest. You need, because if you work too hard, after some days or after 2 weeks, 3 weeks, the risk of getting the disease is much higher.
I couldn't agree more. So just common sense, take care of hygiene, take care of sleep, take rest, protect yourself, protect your colleagues, and be advocates for yourself. Professor Seni, thank you again so much for being on the show, and I wish you health, I wish you luck, and I hope Italy now starts to see flattening of the curve, because you clearly have been severely affected. But thanks again.
Thank you very much for your attention. Thank you.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.